but we'll go through those in sort of introductions in an alphabetical order. So I'm Sai Parthasarathy. I'm from the University of Arizona, and we have here on the slides, if we can go to the next slide, the objectives of the focus group. This is a timely focus group on non-PAP alternatives, namely dental devices and hypoglossal nerve stimulation devices for the treatment of obstructive sleep apnea, considering the current evidence. And the idea is to focus on various barriers and facilitators for adoption and implementation of such non-PAP treatment, with emphasis on access to care, expertise, how we put together a multidisciplinary team, reimbursement, regulatory aspects, as well as contextualize that with the current treatment guidelines, as well as reports from the AHRQ on treatment of obstructive sleep apnea, the SAFE trial, the JAMA meta-analysis, and also most recently the Philips device recall. So the idea here is to identify knowledge gaps and research opportunities, and also practice gaps and practice opportunities. So welcome everyone. We'll go through the internal things about an AHI of 5 per hour. I just worry that many of my patients struggle to be adherent as well. So should it be a composite of what we call an effective AHI, which is a combination of the AHI value and adherence, Rick or others?
So, Sai, I wonder if I could jump in here on answering your question, but also in responding to Rich, who has very correctly, I think, identified where we want to go. In response to what you're saying, I think it's important that we actually at least record that concept in everybody's minds, because there's been a lot of focus over the last 30 years of CPAP at how good the treatment is when you wear it, and very little has been done about including the period you don't wear it. Clearly, if you wear it for an hour and it's perfect, and you sleep 7 hours and it's not perfect or nothing at all for those other 6 hours, there's a problem. And so if you're trying to improve outcomes or physiological markers, you have to take both into account. The effective AHI is certainly one of the things on the table. There may be others, but I wanted to take it in a slightly different direction, which is to sort of highlight the fact that in my mind, there are 2 conflicting trends that have evolved in what we're doing. The first is that there's a lot of work going on to try and get to where we want to go. So people are trying to find ways to enhance CPAP adherence, or for that matter, adherence with any or tuning of any other treatment. That takes time and money. And so, group sessions with patients to get them to wear their CPAP, multiple visits with a dentist to adjust the oral appliance, and so on. Huge amount of investment in proving that something works in the literature and then implementing it. And all of us have opinions on what kind of things work. What I'd like to highlight is that, and I think your question does it very well, there ought to also be a point at which futility is decided upon. And that doesn't have to be complete futility, but I think that if you're still working a year later at figuring out how to get a patient to put on their CPAP or to turn it on, we would all agree that that's kind of like, trying to give somebody chemotherapy as they are dying from their cancer with drugs that are known not to work. So I think what is important for the field is to say, okay, what do we know at which point you switch away from something which has a 95% chance of having failed and try something else, or at least discuss something else, because that's probably more important at this point than what can I do to salvage 1 or 2 patients out of 1,000 who have failed for a period of time. And I would suggest as an extreme version of that maybe at 2 weeks, the data suggests that if a patient hasn't turned on their machine or used it for an hour or 2, you're probably not going to get anywhere in the majority of cases, and you ought to consider something else. There are probably some other metrics that are worth considering, but I would like to hear other people's reaction to, when do you give up rather than what can we do to improve exclusively?
PAP therapy, then I start, because a lot of times, people get referred for very mild sleep apnea that are not particularly sleepy, and they have an insomnia complaint. And we've sometimes oversold the notion that we're going to prevent a heart attack by treating trivial sleep apnea. And that may not be the patient-centered reason that they're coming to the doctor. So alignment of what is truly in the medical best interest needs to be kind of coincide with both the provider and the patient. And we do know that treatment of sleep apnea in certain individuals makes them feel better. And the MERGE trial nicely showed that. And that's not to trivialize that. And the paradox that we have in clinic is the patients that come back to see us in clinic on a repetitive basis are usually very adherent to therapy. But we don't know the denominator. There are people who just go away and they go see Oliver, or they go see Dr. Viviano because they just don't want to have any part of therapy. And I think what the discussion today has to be, how do we really integrate all the treatment options like Joe had mentioned, and not be so PAP centric. PAP therapy works very well in a very important group of patients, but there are people that and I like the idea, and this is what I do in my practices. I say, we're going to start with PAP therapy because it's easy to start, it's easy to take away, but it's not the only tool we have in our toolbox.
Okay.
We can.
So the question I have refers to the 80% adherence that was mentioned for PAP therapy. And so the question I have is that, basically we're talking 4 hours a night, 5 days per week type thing, or are we talking they're really adherent therapy in light of the HRQ and SAVE and JAMA report and everything? We understand that if we're using the criteria of 4 hours a night, 5 days a week, it's not really doing what we expect it to do, right? And so when people are referencing these numbers, and I hear these types of statistics also from my local sleep specialists all the time, I wonder, if so that we can talk apples to apples, so we understand adherence, really they are adhering to the therapy for the majority of the night. Rather than the criteria that has been used for years of 4 hours, because it makes a big difference with regards to how we view that finding.
Yeah, no, that's a great question. I just did want to mention that there is a question in the panels in the Q&A that is essentially very similar to yours, saying that can there be discussion about the HRQ report and the fact that people need to be adherent for 5 days a week, 4 hours. My understanding, Dr. Viviano, is when the EU meta-analysis in JAMA was done, when they did look at the stratified and did a sensitivity analysis on just the patients or the data sets that were adherent. I mean, even in sensitivity analysis in these various studies, if they took the people who are adherent based on that criteria, which is 5 nights a week, 4 hours, or more than 4 hours a night, if you're looking at some observational studies that came from the Spanish group, that there was indeed protection against cardiovascular events and strokes. But unfortunately, the primary study was powered not for that subset, and the primary endpoint ended up being not met. However, in all of these studies, when they did a subset analysis of adherence based on the adherence criteria that we have, there was a signal. I'll pause there to see if I need to be corrected on that. If there are any studies out there where that was not the case, it's probably a good time to do that. But I do agree with you, Dr. Viviano, that many practices claim some exorbitantly high adherence rates that don't seem real. And also, if you look at data, looking at just the adherence in randomized controlled trials, they're always much lower than these convenience samples or population samples or practice-based samples that claim and boast about a 70-80% adherence. We know that if you look at the adherence in all of the intervention arms or all the PAP studies, the adherence is closer to about 50%. So I'll just drop that and move to that for a bit.
Yeah, no, thanks a lot. First of all, I just wanted to 100% say that I agree with what Pat Strollo had mentioned as well. I think that one of the things that we tend to lose sight of is that the major things that patients are interested in. I've never had a patient come up to me saying, oh, I really want to get my oxidative stress down, or I want to keep my airway open, or those things. Like, what they're more interested in is, I want to feel better during the daytime, I want to get my sleep better. And then some individuals are, I'm concerned about my heart and those things. And I think that from my standpoint, those are the two major things that patients are really concerned about. And I think that we need to put that at the forefront. So if patients are having a lot of problems with CPAP such that their quality of life is worse than the CPAP than without, I have a lot of difficulty in terms of getting people to continue the therapy. Because as far as I know, just to reiterate his Pat point, I don't think that there's compelling data, especially in mild to moderate sleep apnea, that treatment of that is going to improve their longevity or their cardiovascular mortality or those things. The second point that I'd like to make is that in terms of the AHRQ or the U meta-analysis, and again, this is kind of more my opinion, I think you need to be a little bit careful extrapolating from some of these randomized controlled trials, because in general, if you look at the SAVE study or the Ricazza study or Isaac study, they do tend to focus very much on individuals who are not symptomatic or are not sleepy, I think for a couple of reasons. One reason is that ethically, it's very challenging to randomize symptomatic patients to CPAP or no CPAP. So I know that our ethics board would not allow me to do that, to randomize someone for 3 to 5 years if they are symptomatic at all. The second thing is, in terms of the patients, I think the patients themselves would not be agreeable to being randomized in a study like that for a prolonged period of time as well. So consequently, in those studies, you get very asymptomatic individuals. So the question is, I think that for asymptomatic individuals, I don't think that CPAP has a compelling signal in terms of reducing cardiovascular disease. But I think it's really coming out from studies by Diego Mazzotti, and then there was a recent Chilean study in chest that showed that individuals who are symptomatic or sleepy tend to have a higher cardiovascular rate as well. And it's probably a marker for the fact that these individuals may have more cardiovascular risk associated with sleep apnea as well. And in addition to that, if you actually look at the adherence rate for SAVE or Ricazza or Isaac, it ends up being very low, again, probably because these individuals are not symptomatic. And it's very difficult to get asymptomatic individuals to use something like CPAP for prolonged periods of time. And that personally has not been my clinical experience in terms of adherence to, I don't think that's mimicked by what happens in those studies. So I think that you really need to be careful about extrapolating that. I think that we need studies of sort of symptomatic individuals. I think it's difficult to do randomized studies, but longer propensity match trials that Alan Pack talks about or Greg Maislin or those things, may be helpful as well. But my own gut feelings in patients with very severe sleep apnea, there probably is some effectiveness in terms of reducing cardiovascular events, looking at some of the animal studies and the short-term physiology studies as well. But again, there's not really a lot of robust clinical data as well.
But they don't look at the first part of the night versus the latter part of the night, because most people wear it for the first part of the night and then they take it off. And then there's all this data, as Dr. Newhouse says, of individuals who have REM-related events, which are usually more severe, and REM-related events, independent of even the severity aspect, have been shown to be associated with greater amount of cardiovascular or morbidity mortality in various observational studies. So perhaps it's not only the average hours, the issue that you raised, David, but also what time of the night is the machine being worn and what time of the night is the machine not covering the event. So very important suggestion, I think, that you brought up with regards to this. What I'm hearing is an adaptive randomized controlled trial design with various therapies being available to just make that AHI zero out, including the Ouija board. Famously, I think we will coach you on that one. Tell me if you want to implement that in your practice. I just wanted to ask you, Bharati, is that a lot of payers are interested in value-based purchasing, and they're interested in patient satisfaction. And patient satisfaction is usually tied to patient outcomes. If they feel better, if the original problem, as Pat and Najib talked about, is, and Rick, they come in with a particular question or an issue. If it got taken care of, they're going to be happy. They're going to be satisfied. So something to be said about global patient satisfaction and whether we are all measuring that in the practice, so that, and I will summarize in a little bit. We have Oliver with a question. We'll discuss that, and I'll have to encapsulate because we have to hop on to the next thematic domain. But thanks, Bharati, for that.
Yes, thank you. First of all, I think there are many good ideas among the things that were already said by the panel members. And of course, the question is quite difficult. What is the threshold or the definition of a treatment success or failure? But I think that I would love to summarize maybe that potentially a 4-dimensional model could be quite interesting, where the first dimension indeed is these patient-reported outcomes and satisfaction or subjective complaints that change due to the therapy. A second dimension should still be the oxygen values and probably all that you could have from data from a sleep study. Measurement of adherence was already mentioned. I think that's, of course, the third dimension. And a fourth dimension in the future, probably it's more feasible than it is now, is to at least have a first assessment of how will the comorbidity or the risk of cardiovascular and other comorbidity be changeable because of all the other 3 dimensions. And so I just like to add that to the whole of the discussion. Thanks.
I apologize for being late. I had some technical issues with trying to find the Zoom link. But I am the director of sleep medicine for Kaiser San Bernardino County, and also the co-chair for sleep medicine for the Southern California region. And I have had a few leadership positions within the AASM, and certainly a big believer in alternative therapies. So very happy to join this discussion.
So the question I will ask is this: in 2015, AASM and ADSM published guidelines on oral appliance therapy jointly. And those guidelines from 6 years ago state that an oral appliance is indicated as a standard of care for any severity of sleep apnea if the patient can't tolerate PAP, or if the patient prefers an alternative treatment to PAP, just patient preference being the guiding thing. So, I mean, that was established based on research that they reviewed, I think, prior to 2013 was maybe the cutoff, whatever, and since then there's been a plethora of more research that, continues to support oral appliance therapy and how effective it is with outcomes and so forth. So I really don't understand this question in 2021. And that, what I quoted out of the guidelines, I know in my local jurisdiction, Ontario here, there isn't any sleep or very few sleep physicians that would be even aware, cognizant of that, the fact that they would be considered a standard of care. And I think that that is an issue because that information is published in the guidelines at the top, has not percolated down to the frontline care providers that the dentists rely on to work with. And just as of 2 weeks ago, one of the attendees from one of my programs called me up because he's having a problem getting the sleep specialist to write a prescription for an oral appliance because the patient can't tolerate his PAP, he has moderate sleep apnea. The sleep physician is refusing to write the script. So this is a real problem. So you're hearing this from somebody in the trenches. I teach this stuff, but also I work this stuff on a daily basis. So that's what I'd like to throw out there for discussion, because it seems like we're asking a question that has been answered before already, at least with regards to oral appliance therapy. Hypoglossal nerve stimulation is a relatively new procedure, so of course those guidelines wouldn't have been established yet.
One of the things with oral appliance therapy that is a challenge is that our dental colleagues and our medical colleagues are not very well integrated with the electronic health record. So sharing of data is quite difficult in the United States, and making sure that the treatment plan is well integrated is a challenge, number one. Number two is, in the United States at least, and at least in our region, adherence is subjective, not objective. We use objective adherence for positive pressure therapy, and we use objective adherence for upper airway stimulation, but we do not use objective adherence to oral appliance therapy, even though the technology exists, although most of the technology is a little bit prehistoric and it's uncomfortable for patients, and it's an extra cost for the dentist. And let's be honest, most dentists who do oral appliance therapy are small businessmen, and there may be a financial advantage to them as well as to sleep medicine doctors who are well aligned with the PAP therapy. As I'll just finish up with with upper airway stim.
As to how many of you agree with Pat's statement that he would never use hypoglossal neurostimulation as first-line treatment for sleep apnea? Either it's a show of hands electronically or real. So I see Rick saying thumbs up as well. So that's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
No, I on purpose mentioned that I could imagine that it would be a first-line therapy, also because Pat saying that it was maybe not possible, because I think in some patients in particular, where you have some arguments and also maybe a profile that is very highly likely that the patient would be a good responder, and that on the other hand, it's highly likely that with CPAP you will only lose some trial time and trial money, then I can imagine in particular situation that this is indeed a potential first line. But again, this is of course for a smaller group of selected patients in which we believe it's highly likely that it will be a successful treatment. So it has many aspects. I would also like to come back to the dental appliances. I do indeed believe, as mentioned by Pat, that when we are starting prescribing dental treatments for an important medical problem, that the alignment between the dentist and the medical community should be perfect. And this is related to going into the medical file, making referral letter back and forth, and having like a multidisciplinary team that does decision making. And in addition, finally, this should be within a dental sleep professional approach, that the dentist is really focusing within his career on this particular treatment.
But Imran is a dentist at the University of Arizona, which is part of an integrated healthcare system where they are able to see electronic medical records of the sleep medicine providers. So, so setting you up there, Imran. So go ahead, Imran, and then please.
Yeah, thank you, Sai. It's there's advantages of being in the integrated medical system. I have records. I have access to patients' medical records, so it makes things a lot easier. And when in the past, when I worked in the private practice, that was one of the bigger challenges. So I echo on Oliver's comments that.
Dr. Lone, please mute your
Thank
phone.
You. And yes, we're getting some feedback. Thanks, Imran.
I had a few more things. Sorry, Sai, was a lot of echo. I wasn't sure if you could hear me. So back to should non-PAP alternatives be offered as first-line treatment? And in regards to the dental devices, we have some smaller studies, not as many, that show that for patients with mild obstructive sleep apnea, and again, we're looking at just the AHI number most of the time, is that for the mild cases, the dental device, we're able to lower the AHI, and in majority of the moderate oral obstructive sleep apnea cases as well. So this really goes back to, giving that patient selection, say, hey, would you give them both the options depending on the severity of their disease? And I've been doing this for a number of years. One of the things I noticed is there's younger patients, they tend to prefer the dental device because they say, hey, I don't want to have a mask and a tube and a machine next to my spouse who is in her 30s. It just doesn't quite appeal. So they say, I want to have something that, I can just slip it in the mouth and not have to worry about any other things. So really it goes back to patient selection, but giving them the alternatives based on what research we have so far, I think that sounds appropriate. Thank you.
So I wanted to suggest that there are some lessons that we could learn from history, because the problem that you alluded to, which is that the assessment of the effectiveness of a therapy which is not predictable, oral appliance being perhaps one that we have the most experience with, but even the others, there's a problem of costs. And I would like to suggest that the institutions like the SRS and the ASM and the European equivalents to those and some of the other country-based associations could play a role here. So when we had CPAP, what was done was we had a titration, and the effectiveness of the treatment was evaluated right then and there with a second night or a split night study. And it took a while, but eventually the payment agencies, Medicare being the model, but many of the others followed, basically set up 3 levels of payment for the evaluation and treatment of sleep apnea. There was a diagnostic payment for a sleep study. There was discussion and eventually some agreement that you would pay for an evaluation study. And then there was the payment for the device and the long-term maintenance, which a few years back was evaluated at 3 months, and they decided whether you would continue paying or rent it for the first part. So there was 3 pieces to the treatment. I think we should learn from that model, and we should be thinking about how to do that in the reversible forms of therapy, mostly devices. So obviously you can't do that for surgery, but you can do it for an oral appliance. And I haven't heard too many models that separate it into those 3 levels. The first being proof that the person has sufficient disease. The second being payment for the evaluation that the treatment actually works, separate from long-term maintenance treatment. And that again is a little complicated in that you kind of pay for the device up front and then use it. But there are ongoing costs which don't necessarily need to be approved. We've all had experience with patients who've had an oral appliance fitted, and we know it doesn't work because we've done a sleep study that shows no change whatsoever, but the patient swears that it's good and wants to continue using it. And I think that, the payment agencies have the right to demand some evidence, either that the AHI goes down or that some metric such as sleepiness goes down or some other proof that this is worthwhile. And along with that comes the issue of adherence. It costs money to put an adherence monitor into an oral appliance. We try and do it, but we are often stymied by the fact that that's basically not possible if nobody's willing to pay for it. And I think the societies should take the position that they require evidence that something works and evidence that it's used as sort of non-negotiable to payment for that device. Patient wants to use something that we can't say works, that's always their prerogative. But if the society is going to pay for it, if the insurance company is going to pay for it, we need proof. That standard probably needs to be pushed for our societies. And we should be saying, look, we want payment for evaluation. We want payment for judgment of adherence wherever that's possible. It's now possible for oral appliance. And if another device comes out, a position, enhancing treatment device, which are out there but not used very widely, the same should be required. People must use it to have it paid for. People must show that it works before we'll consider it. And those 3 payments by the third parties should be separated. It shouldn't just be, if you have sleep apnea, we'll pay for an oral appliance. There should be a gradation. And I think that would help enormously in implementing it. I'll stop there.
Philosophically, we need to give patients options. And I think the answer to that is absolutely yes, even if it simply just allows for the patients to, feel more ownership over their care and management. With that, should, non-PAP therapies be considered as first-line treatments? And I think the answer to that is clearly yes for select therapies, especially for oral appliances. And I think we're going to have to go to that point, especially with the Philips recall, making a big dent into, the availability of PAP devices, perhaps for the next year, and we're going to have to start rationing. We're, going to have to proceed with emphasizing oral appliances for those patients who are considered to be good, candidates. Point number 2, and this is kind of going back to the previous slide. And sorry, I was a little bit late. We are big believers in that we should be managing the patient and not the number. And the number I'm specifically referring to is the AHI. If people have heard my previous talks, I'm a big believer that sleep apnea should be a clinical diagnosis supported by numbers and not a number diagnosis supported by symptoms. But I can share a quick example of a patient who came to me with an AHI of 102 who could not use CPAP because of very severe aerophagia. Put the patient on an oral appliance, and his AHI went down to 2. And the reason that I did that was because, when you look at the sleep study tracings, he had, he had mostly hypopneas, and they were very short, so a lot of arousals, causing him to be symptomatic. So this is a patient who probably had a stable P crit and a low arousal threshold. Didn't take very much to open up his airway with an oral appliances, and his AHI went down to 2. But I think, traditionally that would probably be considered to be malpractice. So we do need to come up with better ways of being able to identify good candidates and how which could be alternative metrics such as, apnea hypopnea indices, distribution of ODIs, and so forth. But I think the overall push is for us to treat the patient and not to treat the number. My final comment relates to Dr. Strollo's, comment about alternative workflows or better integrated workflows. So in our center, we actually have incorporated 2 dentists that are not paid by Kaiser. They are paid, per device, but we've got them credentialed to work in the Kaiser system. So they have access to our EHR, and then they work on site. So we provide them an office, and they do all their oral appliance work there. And it makes for a very, very streamlined process and an excellent experience for our patients. They know that if they have any kind of issue with sleep, they go directly to this one location for all their sleep care. The dentists also then have access to, a sleep study, collaborating and consulting with the sleep physician, because we're all in one site. So that's a model that we've adopted that we found to be very helpful. A big believer in the integration of dentists as a real benefit.
Similar. We're lucky because we have Dr. Almeida who works at UBC. We can send patients and get an expert to do it. And definitely there are individuals that I've sent as first-line therapy to get a dental appliance. They tend to be younger individuals, usually single males, some snoring, mild to moderate disease, those things. I think that would be kind of very reasonable to do. And I do believe that in general, even as an alternative to CPAP, probably dental appliances are underutilized. So I agree with that comment as well. One of the struggles that I have, or the challenges I have, and maybe one of the dentists can comment on this, is that at least in our institution, giving someone a trial of CPAP doesn't really cost very much. It's a fairly trivial cost, and after a month of CPAP, you kind of know whether the person is going to respond or have a good sense of whether they're going to be adherent or those things as well. The problem with the dental appliance is that for someone to get fitted with a dental appliance, it's kind of a long-term commitment, so it's a marriage as opposed to a date. So what happens is they get fitted, they get a few months of treatment and adjustments, and then at the end of that 3 months, probably a substantial proportion of them actually will not really respond to the therapy, and they'll have to get something else anyways after kind of all that cost and all that effort on the patient's part as well. My understanding is that a lot of the boil and bite appliances, they don't really predict who will respond to an actual real dental appliance because of stretching of the jaw or those things as well. But yeah, I just don't know if there's some way to get an idea of who's going to really respond to them so that you don't have individuals paying a lot of money for the dental appliance, or whether the insurance company pays for it. And then, at least in Canada, a lot of times, if the insurance company pays for the dental appliance, then the insurance company will not pay for CPAP, after that, because they usually say, oh, you can only have one or the other. So from my standpoint, that's sort of been my struggle or challenge with using dental appliances in a kind of more broad patient base, because I do agree that in general, the symptoms of the side effects of dental appliances tend to be a little bit less, than CPAP as well.
You brought up nicely, one facilitator, which Dennis was talking about how to bring the dentist into practice, and then, some barriers also that you identified. One of the things in the comments that came up was by Dr. Lee Serkin, who commented about, credentials and specialization or quality of care that needs to be standardized, as well as barriers related to out-of-pocket expenses when people have to see a dentist, and they have to their out-of-pocket costs if their medical insurance doesn't cover is high. And also I can speak to a local barrier, which is a lot of the dentists in certain cities or areas don't take Medicare, Medicaid patients because they don't want to come under the CMS umbrella of scrutiny and rigorous and torturous, regulatory barriers and audits. And so that really leaves out a big sector of certain communities with a higher proportion of lower SES out of the mix, that the only way they're getting it is to go on a payment plan structure to be able to see that. So I just wanted to throw another, barrier there. We talked about some facilitators, and so wanted to throw that barrier there, and I would love to hear the comments from our dentists.
Thousands of patients, I believe, that go untreated for the same reason is they're given CPAP, it's been 90 days, they don't tolerate it, and they're stuck with it. How can we fix that issue? Is, if there was an algorithm to justify, to show medical necessity because the symptoms didn't improve or something didn't change, would be helpful. Along those lines, so the other group for us to involve are the vendors. I think we need to educate our vendors to relay the message to the patients that you have 30 days, because if you don't return it, or 90 days, depending on insurance, if you don't return this machine by then or don't make a decision, you may not be able to get an alternative treatment based on your insurance. I think really patient education on type of treatment and how long they have for the trial period will be very, very helpful for us.
Yeah, thanks, Imran. Those are thorny issues, and I didn't know about the 5-year rule until you sort of brought it up. So I guess we have to, all the more reason we need to choose the first therapy wisely. And based on what David said, if there's a way we can predict that, that would be great.
We're sort of not cannibalizing on each other either. I think obviously we can have a nice symbiosis here at the end of the day.
Yeah, that's a great point. Thanks so much for touching that, because I know I do, if we are diagnosing and treating only 20% of patients with sleep apnea, and there's turf related issues that are going on, there are many comments in the Q&A about, getting credential in these practices, gaining entry into these practices, having to not be able to, for dental practices to work with the DME or with the physician practice as a part of the practice. So many regulatory barriers that are there. It's almost like a silo system at a time that we are diagnosing and treating only 20% of the populace with obstructive sleep apnea. So I really appreciate that comment, Jonathan, that you made. And it also touches upon something that I just want to take a pause and note here, is that we have folks from the dental side, as well as from the respiratory side, as well as, sleep side, de novo, that we are discussing here. And I think we're learning a lot, and I hope the attendees are learning a lot. And that I believe that there's actually this sort of discussions that are very, very fruitful and valuable, as David alluded to at the start of this, is, what are the next steps? Where do you want to go with this? And one of the things I just wanted to say is that it's very heartening to have this combined discussion. And as Craig was, commenting about this, is that there should be more opportunities for societies. And I know Lee Serkin did, a great job being a cardiologist and sleep physician, bringing the dental group and sleep medicine group together to have combined conferences. But I do think that there's an opportunity for the APSS multi-society, multi-specialty, multidisciplinary meetings, that there should be participation by dental societies. You want to get into the mix, you want to get into that mix, and you want to have the discussions and in those professional society and annual meeting venues, and so that these kind of thorny issues can be fleshed out, because there are some barriers that we are not even aware of that exist, both scientific, knowledge-based, as well as practice-based barriers that are there that we could circumvent or overcome more easily if we understand them better and find solutions so that we can present them as a combined multi-society group to the regulatory bodies of the payers, so that they can allow these barriers to reduce, so that, again, we can put that patient in the center of the conversation and benefit the patient directly.
So I wanted to come back to this issue of evaluating oral appliances before paying for them, or separating the payment for the oral appliance into an evaluation phase, which I advocate for. And the issue of the boil and bite was kind of mentioned and dismissed. I think you have to be careful not to throw out the baby with the bathwater. For hypoglossal nerve stimulation, we were successful in getting the payers to approve an approach that was justified, which says we're going to have this relatively expensive procedure, the DICE procedure, where there's an anesthesiologist and an OR, and it's, I don't know what it costs, but it's not cheap, before we will authorize the placement of the device. And if you look at that literature critically, it is predictive, but it's not perfect. And yet we accept that it's good enough. I would suggest to you that the boil and bite, or the what was until recently available, the matrix titration device, made a prediction, and it was not perfect. But in fact, I think it was probably pretty good at, making an improved chance of success. Certainly, if you have a boil and bite and you have absolutely no benefit, I think that can be taken as a sign that this is going to be a difficult patient, where you might want to consider a more aggressive push of another therapy, such as CPAP. Whereas if it's dramatically effective, but not perfect, you might want to say, well, I think I can do better with a definitive device. This should be paid for. And I would suggest that we should take the same approach, not throw out a treatment or an evaluation procedure just because it's not perfect, but rather push for the idea that it stratifies the need for reimbursement. So I would argue, if I was making a pitch to Medicare or CMS, that they should pay for an evaluation with a disposable, or, they'll put forward a relatively low reimbursement, so that the dentist is encouraged to come up with a way to decide how the patient will respond. And then a separate payment, an additional payment, if it's successful, and no further payment until the dentist submits some kind of now literature proven therapy that is an alternative. I think that would make an enormous difference in the number of people who were evaluated for and therefore shown to be effective, as well as the people who were not given oral appliances and pushed back towards CPAP. And it would solve some of the problems of, which therapy do you go with first? It would allow people to evaluate and triage, rather than saying, well, boil and bites don't work, or the matrix therapy isn't available anymore, but some other form of that may come out shortly. And you would use that and say, well, that will triage me and give me an 80% chance of success instead of a 30 or 40 or 50% chance of success with my oral appliance. And that's what I'm going to pay for.
Yeah, great point, David. Dr. Van der Werken agrees with you as well. And I like the way he said that, it should be something like a DICE for MAD and not a, boil and bite kind of situation. But I did want to give the dental providers, an opportunity here. I just didn't know whether a short-term predictor is actually, going to be good or as good as 80%, and whether some of those changes won't be seen at the short term, like a DICE for MAD, but it's something that's an effect of time in how the ligaments pull, stretch, and whatnot. So just wanted to pause there for a second to give the dentist an opportunity to respond to that as to whether there's a predictor tool or approach that can categorically exclude people who may not be successful candidates. Any takers? Imran.
Yeah, so with the dental devices, it's a gradual advancement of the mandible. So if we do boil and bite, and we just start them, bring the jaw out all the way in a short period of time, we know within 2-3 days, they may develop TMJ pain or myofascial pain in the muscles of mastication. Then that will automatically deem as a failed treatment. The ideal way to do a dental device is to start them with just a slight protrusion of the mandible, and over 6 weeks, or some take even longer, is you gradually bring that mandible forward. They're giving the ligaments, the tissue, time to stretch and get used to being stretched gradually over time. So really, in the short term, with boil and bite, really it's not going to give us a good predictor to say this is going to work for you or not going to work for you. Majority will say, my jaw hurts, I can't use it. But if we compare them to say, we're going to give you a dental device and gradually bring that jaw forward and then see how well you're doing with it in terms of your sleep apnea, in terms of your adherence, that sounds like a better approach.
Dr. Viviano, thanks, Imran.
Imran, I agree with you 100%, and that's the way I provide oral appliance therapy in my practice. I start off very conservatively and work towards the optimum position for exactly the reasons you stated. Now, this makes it difficult to do a one-night study at an optimum position. That's what, guessed at like 70% or whatever, to see if oral appliance therapy work, and then use that to determine whether an oral appliance is an appropriate approach. This is one approach that's being used right now with the apnea guard, and a certain percentage of the time it's predictive of working, and that approach. Interestingly, when Dan Lewandowski published a study with the apnea guard on one side, and on the other side was custom-made appliances, the apnea guard actually got better results in that particular study than the custom-made appliances. Custom-made appliances didn't control for vertical, for drop of the jaw, so maybe that had something to do with it. Nevertheless, it demonstrated a certain efficacy that typically is problematic sometimes with these over-the-counter, boil and bite type of devices. At any rate, one of the things Dan Lewandowski has done very recently, and I just heard about this, it's created a software package that he's put out free for everyone, and it's to optimize Oral Appliance Optimizer. I can't remember the exact name, but nevertheless, what it does is over 3 nights of home sleep test, the device of your choice, as long as it also captures a position. And he evaluates baseline, then with the apnea guard in place at 70%, and then with some type of a positional aid, like for instance, his night shift, or it could be something else that's keeping the patient off their back, and then does an automatic calculation and determining whether PAP is the only thing that's going to help this patient, or positional therapy alone will help this patient, or oral appliance and positional therapy is the optimum, or the oral appliance is what's needed. So, this is an automated system that could be used if one discounts the concern with night-to-night variability. There's always limitations to whatever one does, but we have so much cool technology available to us. And this is creative thinking to see how we can come up with solutions. This is just one approach. And I thought I'd throw it out there because I think it speaks to a lot of what we've been discussing right now, and that the payers may be interested in this type of approach to fast track to a solution. Realizing, as Dr. Rappaport said, there's no perfect approach that we can take. Because of the reasons Imran mentioned, that with oral appliance therapy, sometimes it takes 3 months before you get them into that optimum position, before they can comfortably manage wearing their appliance in that optimum position. So how are you going to get a quick answer for that particular individual? There's always going to be patients that you cannot capture the most accurate information for with how well an oral appliance will work. Thank you.
I am going to throw my support behind David Rappaport. I kind of have to because he's my mentor. But we have an extensive experience with using temporary boil and bite oral appliances within our setup. I don't know how many we've done. We've certainly done hundreds. And we did publish as an abstract, I believe, a couple of times. Our experience in looking at at least the positive predictive value of those who respond to the temporary oral appliance to the custom oral appliance, and the positive predictive value was greater than 90%. The patients also, were able to use the temporary oral appliance as a way to kind of gauge whether they like the oral appliance and they think that they would use it long term. And then finally, because the custom oral appliances can take some time to deliver, the patients had a bridge therapy until they got their custom oral appliances. So I think there's a lot of benefits potentially to using a boil and bite. Now, having said that, there's perhaps a couple of areas of possible research. First of all, and I know Dr. Bogan had said, oral appliances and non-PAP therapies are 50% effective, and it's partially it's true, but there's a spectrum there, right? You have some patients who respond, 0%, and some patients who respond 100%. So really, trying to identify good candidates is really the key to this, especially since I think a big barrier for a lot of sleep clinicians is not knowing or not having the confidence of who's going to be a good candidate. The other area is certainly of research. I know there's been a little bit of work here is, and this relates a little bit to the previous slide, how we define effectiveness. What's better? An oral appliance that's 50% effective for 8 hours, or CPAP that's 100% effective for 4 hours, and then they rip it off and sleep for another 4 hours. And so trying to understand, the AHI, with a proper ratio of sleep time, I think is going to be critical. And with the onset of wearables and so forth, I think we may be emerging into a period in which that may become more possible.
Quite a seamless referral system. We have the referrals built into our computer network. We print off the referral, the order they need to get a sleep appliance should they want it. We give them a copy of their test. They go to the sleep dentist. For some reason, we have a cluster of boarded dental sleep medicine specialists right around us, and they in turn send the patients back if the patient chooses to proceed with the appliance for a follow-up home study. So that our referral docs understand that that's part of the process now. We understand how they work. They've gotten in network with the insurance companies. So the cost of the patients is less. The referral is simpler. Patients sometimes still choose not to go that route, frequently due to cost. But now the patients have made a decision that's based on their own needs versus us denying them any care. And so we've seen a real uptick in how this works. One last thing, dentists, and one of the two of the dentists in the past would discuss with us how we weren't referring enough to them. So we audited that process. And what we were able to talk to our sleep dentist colleagues about, again, in the most respectful way, was that the friction in the system actually was the patients not seeking out the care. It wasn't us denying them access. And so we were able to work on that piece of the referral process. Patients were either not calling them or were calling them and not scheduling an appointment for a variety of reasons. And instead of it being an accusation that we weren't sending the patients, it became, how do we make that flow better, and in turn give patients an option to come back as well. So if they decided they didn't want to get the oral appliance, they could very seamlessly come back and see us. And so that sort of network approach of non-financially related organizations, and we make it clear to our patients that we have no financial interest in whether they get an appliance or not. It's in a very honorable way. And so every organization has financial issues. So being unaligned with any of the major hospital systems to us is a purer financial situation. The hospital systems have their own set of financial incentives, which are quite dramatic. And so we should just recognize that they exist for everybody. But in closing, we've taken the approach of collaborating with our dental sleep colleagues, and they've responded in kind in the most professional and appropriate way. So we've had an extremely satisfying relationship, and it's a bit intellectually distressing to hear that that's not going on in other places. But for us, it's been quite satisfying.
How many of you would offer a dental device as first line of treatment? Raise of hands. So I see 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay. How many hands down, electronic and real? How many of you would not offer dental device as first line of therapy? That could show 0. And so having said that, I I did want to throw out some of the multidisciplinary talk that has already come. I think it's a great model that Dennis shared about, dentists having a credential but not being part of the practice. Imran Patel is at the University of Arizona. He's actually, employed physician, but he has his own, DME, and he's a separate, cost center and all of that. So there are models that can be operationalized, and of course, prior to dentists being in our sphere, we did, refer a lot of our patients out to a couple of dentists in town. But there were some, barriers which were, very nicely articulated by Joseph. So I just wanted to throw out these two sort of ideas and models. There's a very nice paper that was forwarded to me by Dr. Sunil Sharma in West Virginia University, who wrote an article about how, dental sleep practices can be incorporated into a multidisciplinary practice. So I would suggest you all, find that article. I apologize, we don't have a references, included as part of this.
One approach that we've been using, that I think other institutions also do, is that we bring in the dentist as an adjunct clinical faculty. So what happens is they're embedded within our clinic on certain days of the month or week. And then what happens is, our fellows can actually rotate to that clinic so they get the teaching experience. The one part that's always been a little bit of a struggle is because the oral appliances are considered DME. That part is a little hard to finesse, because the dentist that we brought in, she actually has a prior practice, so it's a little hard to get that piece. But so what she mainly does is she goes over the evaluation, the fitting, and then the follow-up care. But the DME part is a little bit a difficult thing that we've been struggling with.
Similar experience that we obviously been working with Rob Rogers for many years, and our fellows rotate through his clinic as well as Ryan Seuss's clinic in ENT. The issue of multidisciplinary clinics comes up, in my role as chair of medicine, and it's a very patient-centered approach. We do this with our ALS clinic, but the fundamental problem is it's not very cost effective trying to get multiple providers in one site and be very efficient. And where these clinics succeed, on the UPMC side, are usually in CF and in transplant, where there's high dollars associated with supporting these efforts. And unfortunately, we just don't have that in the sleep space.
There was a question in the chat group. I just wanted to say that of at least one practice out there that was actually having barriers for getting CPAPs, and they were reserving CPAP machines. But relevant to what was just raised in terms of the dental practices is that there is a request from one of our attendees that perhaps the American Academy of Sleep Medicine and Sleep Society should, some legislative action, approaches for how, there could be better access for care for dental devices and such. So, in terms of insurance coverage, as well as, oral appliance being a first choice. And I know I'm talking regulatory side. There was a comment from Rashmi Parmar, and Imran, is very pertinent to you, which is that there is apparently a software glitch in Medicare that for the E0486, when it's submitted, there's an automatic rejection for the dental device. So it may be a software glitch that was commented upon. So you may want to look into that.
I would just say, we actually have a dentist in our practice, and it's complicated from a regulatory perspective, but we use a dental service organization platform to sort of spread the risk and to meet the legal aspects of it. But it's been amazingly valuable to have a dentist on board that I can walk down the hallway and talk to and align with. And of course, we work with other dentists in the community, but it hasn't worked as well. I mean, there's some value, obviously, in having that person. And again, our process has been through this dental service organization. So,
Fully agree with Dr. Bogan. Incorporating dentists is very valuable. Quick answer to the multidisciplinary model. Agree with Dr. Strollo. Conceptually, yes. And in fact, we've incorporated behavioral sleep medicine team. We're in close collaboration with pulmonary, peds pulmonary, inpatient pediatrics, all patients who, little babies who are sick, they get transferred to our NICU and we study them. And all these teams know to directly contact my case managers rather than the physicians. So it's very much a team effort with multiple disciplines, and the one-stop shop model, I think, creates both a better patient experience as well as a provider experience because they both know where the hub is.
Discussion on the multidisciplinary approach, and I know of a number of centers around North America that have pulled it off and do very well with it. Just like to suggest that there's something else that we'd like to bring to the table here in the discussion, at least thinking, a better collaboration between physicians and dentists would open up so much more care to patients. And Alberta, Canada actually has that in place with guidelines that were written by all the stakeholders, the physicians and the dentists and so forth, the associations. And so we have the dentists there on the front lines, owning sleep testing equipment, dispensing it, reporting, doing all the proper evaluation like they've been trained to do, and then reporting and working with a board certified sleep specialist that's making decisions and so forth, and then working collaboratively together. So they're not in the same office, but it really is a multidisciplinary approach, and they are a model as to how this can be done, but it requires some changes.
One comment. Can I make one comment based on what John just said? Because I think there's, if we're going to talk about the success of, oral appliance, moving into the future, I think there's one thing that we haven't discussed that's kind of the elephant in the room that probably needs to be put out there, which is there's a lot of distrust between the sleep physicians and the dentist, right? The dentists feel like the sleep physicians, don't believe in their product and are just trying to make a lot of money, and they're trying to do things that are outside their scope, right? And that's how many sleep physicians feel. So for oral appliance, I think to become successful, we're going to have to bridge that gap some way, and the way to bridge that, I think, is a much larger discussion that we're not going to be able to do in the next 30 seconds. But I think if we're going to be successful with this, that's an issue that's going to have to be addressed.